I'm gonna have the panel sit up here. Come on, Travis. And choose a seat and then just know that you have to be pretty close to the microphone. All right, thank you guys. So I have the pleasure of introducing our panel. And the goal of this session is really to showcase a few of the incredible organizations that are moving us all forward in the harm reduction space. So you'll hear what it means to be ready and available in the moment to support someone in their active use to reduce overdose risk, to support safer smoking as a means to keep all drug users safe, not just those who inject substances, to truly meet people where they are in the community, and to look critically at how we don't cause more harm in responding to overdoses. And so the common theme bringing all of us together is providing dignity to those people who use drugs and meeting their immediate needs and supporting them and asking them in the moment, how can I be there for you? And the format of this panel was really born out of everybody's interest in seeing more harm reduction focus and more lived experience at this conference, which unfortunately is only 7 hours. And so we had so many amazing people respond, and we're hoping to use this time to really showcase four areas that there's really exciting stuff happening in our state. And so I have only given each presenter 10 minutes as a TED Talk-ish style to really share what is most meaningful to them about the work they do, what are some of the challenges, what are some of the successes, what are the practical tools that they are using. And I hope that everyone leaves with four kernels that they can bring back to their practice, to their patient. And so I want this to be really a tangible moment for everybody. And then I am going to sort of keep us on time, but otherwise sit back. This was a slide I meant to show while I was doing that. And I have some warning objectives. So I'm going to first pass it off to Dr. Alex Walley.
Oh, it only gives me 7 minutes. I want 10 minutes. All right. Thank you, Jess. I'm so happy to be here. So happy to be at the whole conference. I've learned a lot each day, and just really proud of what's going on among substance use care providers in Massachusetts. So yeah, my name's Alex Walley. I'm a general internist addiction specialist at Boston Medical Center. I also have a role with BSAS as their medical director, and have been involved in naloxone for a long time in Massachusetts, but not going to talk about naloxone. I'm going to talk about what else. And one of the things, what else, is SafeSpot. When you look at that phone number, you're going to get a lot of chances to write that phone number down. We have a table outside where we have some swag. I recommend the stickers. I'm really here representing, as the medical director, something I'm a small part of, which is a group of people, many of whom use drugs themselves, and who are really trying to make a difference. So I'm talking about SafeSpot. I'm going to set some context, which is that stigma fosters unwitnessed overdose. And so I've been working on naloxone and overdose prevention since 2007. And the thing that I'm really focused on right now is unwitnessed overdose. Why does stigma foster unwitnessed overdose? Well, there's a lot we don't know about the people who use drugs that put them at risk for opioid overdose. There's a lot we don't know about non-fatal opioid overdose. And so that really is what's driving why people use in an unwitnessed fashion, why people use alone. It's sort of human nature. It's not just stigma, but stigma is a big part of it. People feel safer and more comfortable when they're using alone. It maintains their privacy. They avoid the stigma. It's convenient. They also can avoid theft or violence, depending on what else is going on in their life. Now that we're in the 10th year, really, of fentanyl and the surge in overdoses that we've seen since fentanyl in our drug supply, there is fatigue among both survivors of overdose and rescuers of overdose that I actually hadn't thought of and wouldn't have imagined. So what that fatigue does is it means that, yeah, like the response to the non-fatal overdose often results in too much naloxone, which results in a lot of precipitated withdrawal, which is okay in any one instance. I'll allow it because it saved that person's life. But if it's if you have the regular experience of putting somebody into precipitated withdrawal, that starts to get to be a drag. And if you're somebody who's regularly been put into precipitated withdrawal, that also gets to be a drag. And so over time, what that means is people are going to be less likely to want to be around people who are overdosing. And it's less likely that people who are overdosing want to be around other people who are going to put them in precipitated withdrawal. So post-naloxone adverse events. Here's where we're talking about the adverse events that come from naloxone. You get withdrawal due to high doses. And now what we're seeing in the marketplace and the marketing is driving of higher and higher doses of naloxone or longer and longer acting antagonists. And then there's that especially unexperienced rescuers have of anger or excitement or drama when an overdose rescue occurs. And that can be mitigated by communication. I'm really setting up in many ways what Tehya is going to talk about around the compassionate overdose response that's happening at Boston Healthcare for the Homeless, but I want to at least touch on it. Okay, so I want to advance the slides. Okay, so we don't know a lot about people at risk for opioid overdose, and we don't know a lot about non-fatal opioid overdose because of stigma. What we do know a lot about are people who actually die from overdose after they their cases are reviewed by the medical examiner. And greater than 90% of deaths occur during unwitnessed overdose. That's in Massachusetts and nationwide. Okay, so in an unwitnessed overdose, naloxone doesn't work. So 90% of the overdoses that are deaths that are currently happening right now, we can distribute more naloxone and it's not going to impact. The only sliver there is that 10% where somebody was actually there and maybe they didn't have naloxone. But even if you are there and don't have naloxone, chances are that person's not going to die. You're going to do something. You're going to stimulate them. You're going to rescue breathe for them. You're going to do something. Okay. So I love naloxone. I think we want more naloxone. We need more naloxone out in the community. Everybody needs to have it, but it's not enough. It's not going to help us with the unwitnessed overdoses. What will help us is having somebody there. And the best evidence-based approach to having somebody there are overdose prevention centers or drug consumption sites. So this is an organization that is now supported by many, many mainstream organizations. You can go there, lend your support, lend your voice. We got very close this year to passing an overdose prevention site bill. There was support in both houses. They just couldn't get their act together to actually pass the bill. And so next time, hopefully, but there is a coalition now that is broad, that is deep in Massachusetts to make this happen. So I encourage you to look into that. What this bill will do is establish a 10-year pilot program of overdose prevention sites. That's not going to reach all of the people who are having unwitnessed overdoses every day. It's going to help some people, but it's not going to help other people. So we need more interventions for people who are facing unwitnessed overdose. So that's where SafeSpot comes in, also known as the Massachusetts Overdose Prevention Helpline. It's a 24-hour, 7-day-a-week phone service with trained peer operators who make a safety plan with people using opioids, people not just using opioids, actually using any drugs alone, and they spot them and send help when needed. So I told you about the rationale. Since the line started in October 2022 and through last month, over 5,000 overdose events were spotted, exactly 16 overdose response activations were done, and there were no overdose deaths. Operators, I just mentioned many of the operators are actually people who have used the line previously, who have raised their hand and put themselves forward as people who want to work on the line. There's pretty extensive training, actually. And now, thanks to the Massachusetts Department of Public Health, after the RISE Foundation supported the groups, all of the operators are actually paid on a per diem basis. So these are paid positions. The hold time is short, about 15 seconds. And I said it was mentioned by it was funded by the Department of Public Health, but calls are taken from over 32 states and Canada. So please share this with your patients. Well, if you want to put this contact in your phone, if you scan this QR code, it'll actually put the number directly in your phone. And then I encourage you to actually share that with your patients. And what I've been doing is actually calling the line while I have the patient in the office so they can hear what it's like to be on the line. And it's kind of like what I used to do with naloxone, I still do, is for those who say, I don't need that, it's not for me, I'm like, well, you know somebody who could use this. So let's call the line together. I want you to hear what it's like so you can tell your friends about it. Okay, so and this is the safety plan here, which is the information that the operators take down when somebody calls. So they do get their name, although they can give a false name. They just want to be able to connect with the person on the phone. So they do get their name, they get their address. That's important because if they become unresponsive, they have to send somebody to that address to get help. And then how to get in. Okay, so there's very specific safety plan instructions that the operators take down to make a rescue possible if it's necessary. This information is not kept in an individual level. The court calls are actually recorded to make sure that we maintain quality, but those calls are all deleted after 7 days. I think that's the main things I want you to talk about. I'm around at the break if anybody wants, and we have that table. Okay, and then if you want to like really get motivated, listen to This American Life episode that was really about how these helplines work. Because of time and the rest of the panel, I'm just going to go through these very quickly about compassionate overdose response. So this is the normal paradigm that we've had for years about how to respond to an overdose. Here's how it's starting to change because we know of the toxicology in the drug supply. Yes, fentanyl is the #1 killer, but the majority of people who overdose and die, they die with other substances along with fentanyl. Okay, so multiple sedating substances are common. They cause unresponsiveness. They're not immediately reversed by naloxone. So titrating naloxone to normalizing breathing really needs to be the focus of overdose response. Alertness will come with time. A lot of people are administering naloxone in order to get people to wake up and be alert. But if they have xylazine on board, if they have benzodiazepines on board, if they have alcohol on board, that's going to take time. And that's not going to be what kills them. So we really want to get people breathing again. We want to provide rescue breathing when people are able, while the naloxone works, and when naloxone is not available. We want to remain calm and communicative. That's really important at the scene of an overdose. You're going to be okay. That's what the message is. Not what did you do? Why did you do it? You know, how could you do such a thing? Okay, that's it. Thank you so much. Really honored to be followed by Jim Duffy.
Thank you, Alex. My name is Jim Duffy. I'm the director of Smokeworks. I had 10 minutes to something between not enough time and eternity. So we're gonna do this. So Alex set up a lot of what I'd like to touch on. One of the things being polysubstance use. It's kind of under-addressed in harm reduction, but I'm gonna back it up just a hair. I'm really grateful to be here. I'm a person with lived experience and living experience. I have, as my mentor says, a complicated relationship with some drugs, an honest relationship with others, and a very functional and exciting relationship with other drugs as well. It's a spectrum for me. I've been on the ride for a while. Here I am. But I wasn't introduced to harm reduction until like 2018 when I walked into the AHOPE Needle Exchange in Boston. It's my example because it's my needle exchange. It's not the only one. It's not the only one doing fantastic work. There's reps here from all over the state that have relationships or work in similar programs that are doing amazing work. I'm going to talk about AHOPE because it's where I saw what harm reduction does for folks. Meth was my drug of choice. Meth was my complicated relationship. Meth was, in 2018, what seemed to have us all going, oh my God, what do we do? When we had been trying to respond to pivot to the fentanyl contamination of our supplies and the rising opioid use in general. And polysubstance use snuck in and kind of took us by surprise and gave us all a little bit of a whiplash, as though it weren't a thing before. What I saw in AHOPE was just, it blew my mind. I had never walked into a service center, harm reduction program, drop-in, whatever. So my first, understandably, I hope my first impression was, well, where the hell was this for me? And my friends and my people and others. And I saw that reaction duplicated time and time again Well, we're serving 100 to 150 people a day through brick and mortar site, through outreach, through mobile services. It's my job to go out there and find people and figure out what they need. And hopefully I've got it for them. And very cool that I might be able to go and walk around all over the city and have something for 8 out of 10 people. But 2 out of those 10 are going to say, what do you get from me? I don't inject. I got a peanut butter sandwich and a juice box. You know, that's as good as it gets sometimes. We walk out of A-Hope after seeing 150 people a day doing amazing things. Tabletop FTIR drug checking, free anonymous, low threshold, no threshold, HIV and STI testing. You need a referral. We're going to go into Boston Medical, pull somebody up by the ear to see you. Connections with healthcare for the homeless, same day prep. Amazing stuff that can happen. But we walk out, patting ourselves on the back after a good day's work. And there's a sea of 40, 45 people who we don't know the names of, smoking crack outside, smoking meth outside, because there's no incentive for them to walk into a needle exchange. And that was the problem. For myself as well, seeing all these things that could have benefited me back in the day. I'm a person with HIV. I'm a person who never had a community or place to talk about prevention, education, to get tested, to feel like conversations about drug use could be had in open air. That's what those service centers offer. Now that I've gone completely off script, I'll start the slides. We're here because this is what people tend to hear about safer smoking, injection alternatives, and pipe distribution. Starting on the left, we have New York City that is outraged that we would give lip balm with crack pipes. In the middle, we've got the West Virginia watch. West Virginia, one of 2 states that passed laws specifically banning pipe distribution. That's West Virginia, where a bill went to the governor with about 30 days time because one council member said, I like this, and now it's over. We also have Idaho, who had a pipe problem that the backlash was so heavy that needle exchange services have been suspended at the moment, though we're hoping to see some progress to reinstate those. I come to you today with this awesome opportunity. Sometimes I frame this as part and parcel, and it certainly is. This plugs into needle exchange, amplifies all the benefits that we've been seeing for decades. But the truth is we're still fighting for liberal access there. So let's not even go there yet, because we're still fighting that fight. And here we are trying to like tack on something else. We have a lot of providers here who are a step removed from maybe like the street outreach. Please tell me if I'm wrong. I don't mean to be assumptive here, but what happens along the way to get people to your office or your doorstep sometimes is long, slow engagement for time's sake. I'm gonna call on Dan Biggs' words and remind us that the goal is any positive change. And that can look like a lot of things. And I could take you the rest of the afternoon telling you about how this increases engagement, how this fills in gaps and creates some equity in harm reduction, which has been overly focused on opioid injection when we have polysubstance use on the rise, and communities who have been dealing with substance use issues, crack cocaine, anyone? For decades without any harm reduction services. But I'm gonna go back to the really brass tack stuff. It's when I have got a backpack and I'm walking around, and it's been a while, when I'm walking around the city and I'm doing my job to just try to keep people safe for a day. My goal is just to make someone's day every day, just to have something that can make it a little bit easier. And in that realm of work, like a pipe can do that. A pipe can honestly do that. I don't want to skip over our wonderful Boston Herald headline, city handing out drug pipes and safe injection bags on mile. Not for nothing, but that's Bobby Kraft getting married in the top right. He funds some vans. MMWR, February of this year, scary headline. Roots of drug use among drug overdose. We're seeing evidence of smoking supplies at overdose scenes, fatal overdose scenes, increasing while evidence of injection supplies are sharply decreasing. That's shocking and slightly misleading. We don't have the time to dig in, so let me give you the highlights. There is a major cultural shift to smoking among people using drugs, opioids, and stimulants for many reasons. Chief among them, those safeguarding themselves against the contaminated supply and lack of access to other supplies too. So I'm sorry. CDC recommends reduce overdose deaths by strengthening harm reduction services for smoking. Harm reduction programs have adopted safer smoking supplies to reach new drug using populations. We are a step away, obviously, from being able to say the CDC wants to give out crack pipes. But the law, policy, recommendations, and guidance has always been years, if not decades, behind harm reduction. My goal today is to get you to think about this a little bit differently just for a moment. And in your practice, you can do one or two things with me. Exercise for a moment. Think of what your practice might look like without needle exchange. That gap, what you might think is your answer to that question, can similarly be the answer to the question, what would things look like without safer smoking supplies? It's part and parcel. We have so many issues we could focus on for a moment. One that I'm going to talk about on this slide very quickly, and this is only on smoking stimulants, shows us that a vast majority of people not only smoke as opposed to inject their stimulants, but do so for a variety of reasons. Self-care is on here, and that's very important. Preference, just general preference, also something to note. But on the tails of everything Alex was just telling us about safety and spotting, we see 27% on this survey of 933 people. This is in the Pacific Northwest 2021 out of Washington State University, reporting smoking as their preference for the social aspect. And I'm going to highlight that. I'm going to sit with that for a second, because when do we lose people? We lose people when they're alone. Like most that we could talk about today, this isn't the answer to everything. This isn't the answer to our overdose crisis. This isn't the answer to inequities in healthcare and harm reduction. This is a piece of the puzzle, but it's a major piece of the puzzle that we haven't been able to implement as successfully as we should over the years. Just to back up what the CDC has told us earlier this year, and to highlight how important it is to talk to the experts who are at our fingertips, our patients, our participants, our friends, our family. We didn't need the CDC to tell us this in 2024, because people have told us for a very long time what they wanted. To the previous slide, people have been smoking to safeguard themselves against the ills of injection. I'm at AHOPE or any needle exchange. You walk in for supplies, I've got one job: to get you as much as possible and make sure you know everything that's available to you, right? Bag of smalls, cookers, cottons, waters, ties, alcohol pads. Let's get some test strips in your hand. Remember, that's 3. That's benzodiazepine and fentanyl test strips. And you'll want a backup because they're not great. So that means you want twice as many rigs now because you want a backup shot for each, twice as many cookers, if not 4, because come on, we give you 2 cookers with 10 needles. Good luck and not go and get Hep C in the first place. I'm going to ask you to go where? Outside. Take 10 to 15 minutes because of my advice on best practice. Test each thing, have a shot, test it twice. You got vein fatigue, you've been shooting coke. You got to take you another 15 minutes to find a vein. Every minute that you're out there, you're subject to theft, violence, or arrest. The intuitive use of pipes can help skip a lot of those issues, those ills. Sorry, went straight past that. We definitely see what this has done on the larger scale. I want to focus on the third bar, and I'd love to talk about report greater engagement of existing clients. It's fantastic. New participant engagements, reduced injection. That's all amazing. But look at the third bar in. I got cut off a bit, but 47 people, 47 programs responding to this survey reported happier clients. And that's just the end of the story for me. If we're making people happier and keeping them safer and keeping them coming in, we're doing our job well. I'm just going to finish by saying, the first thing that blew my mind about it was back in the first year at AHOPE. I did this for engagement. It's my job to meet people. I need tools for engagement. Of course, I could think of the ancillary effects and the safety. It's great, but I didn't see it until we had 2 things. Vitamin C was about the only thing we carried around for injection. Ascorbic acid is going to be used to break down crack cocaine for injection to make the rock a liquid so it can be injected. Hottest commodity on the ad. Can't get it on the weekends, not sold over the counter. I never came back with any in my pocket, any. I go out with pipes in one pocket. All of a sudden, I'm coming back with vitamin C. Not everybody wants to inject. It's not everybody's preference. I really appreciate this time because I just want to give you an opportunity to think about this a little bit differently. Put yourself in the shoes of people who had to promote syringe exchange 10, 15, 20, 30 years ago. You're those folks now, and you can help us move the needle on this. It's misunderstood, miscategorized, and demonized. But I hope the next time the conversation comes up, be it in the workplace or elsewhere, we've given you the opportunity to think a little bit differently about it today and have a better conversation with folks who just think that's just going a little too far. Because once syringe exchange was going a little too far. Not long ago, naloxone distribution was going a little too far. I thank you all very much for this time.
Hello, my name is Rachel Leschernier. I am a prevention specialist for the prevention and outreach team at Manet Community Health Center. As Jim said, we're very similar to A-Hope. We do all the things A-Hope does. We just do them a little outside of Boston. Our program is all grant funded. And we do things like provide free STI, HIV testing and treatment. We offer syringes, pipes, and all the supplies that go with them. We do street outreach and work a lot with the homeless communities of Quincy, Braintree, and Weymouth. We work with several police departments to go out on overdose follow-ups with the community police officers. We will offer support for the survivor as well as family members. We are made up of a team of 5 prevention specialists, a manager, and a data coordinator. Soon I'll be transitioning into the prevention nurse position, which will be exciting to offer some medical insight into our program. We are very lucky to be part of Manet Health Center because we have that direct connection as A-Hope does with BMC, where we have our providers, we have our MAT team, we can get people those referrals right on the spot. Couple numbers from last year, we distributed 4,884 doses of naloxone. Our SSP program had 183 total participants. We gave out 127,143 syringes. We took in 232,650 syringes. And we had 883 total client engagements. Some of the referrals that took place last year, we had 87 direct primary care referrals, 13 behavioral health referrals, 16 Hep C navigations, 26 substance use disorder referrals, and many more because we have our own substance disorder team that takes people in directly. And then we had 28 direct referrals from our program for PrEP. Our program, although we are part of Manet Community Health, our office is separate from the clinical locations. So it gives our clients an opportunity to come into a non-clinical setting that is very comfortable, very open, very comforting. We strive to provide relationships with our clients with no stigma and no judgment, which is huge. Probably the most important part of our job. Also, that helps us build relationships with our clients. We look at meeting people where they're at, whether they're currently using, where they want to make a change, whatever that looks like, we're there to help them in any way we can. And again, building relationships and networks with our clients just keeps them more engaged in any services. There's several challenges of this job. A lot of them have been mentioned throughout the day today: insurance, stigma, just general lack of treatment facilities, whether it's mental health or substance-based treatment. There's just not enough out there. So it creates barriers for the people that we serve. Though, again, so much success in prevention has come such a long way in short time, and we have so much more work to do. So probably the most important question, or the most, not only do our clients face so much stigma, but the work that I do, whether it's from people in the recovery community, people in the medical community, people in general, do not always like the work that I'm doing. I myself am a person in recovery. My job helps me every day to stay on my own track. The question I get all the time is, does harm reduction enable substance use? Absolutely not. I can't answer that enough, and I often answer by telling people I look at my own recovery. Recovery to me is a journey. Everybody's journey is completely different. No person is the same in their recovery or where they're at. There's times that I know within my own experience where I was completely hopeless, had no motivation, nothing was ever going to change in my life. But when people come in to utilize our service, how I'm looking at those people is if they're walking through that door, whether it's to get a cup of coffee, clean supplies, get tested, or just to talk and say hi, those people are walking through that door with some kind of hope. They're ready to make some kind of change. Change is change, no matter how big or how small. My role is never to force treatment on anybody or tell them what they need to do. But the most important part of my job is listening. I was lucky to have a great support system. A great support system in my recovery. Not a lot of people have that. If I can open my ears and my heart and be that person's support, they're coming in that door with some kind of change in mind. My job is to keep you alive as long enough as I can so that you can continue to make those changes and continue to make positive choices. Recovery is possible, but it's not a straight road and it's not easy. But kindness and compassion goes a long way. And I'm very happy to be in this room with all of you and see the amount of compassion and caring for the work you do. So I want to thank you all for being here. And thank you for what you do as well.
Good morning, everyone. My name is Tehya Johnson. I'm a nurse practitioner with Boston Healthcare for the Homeless, and I am our Associate Medical Director of Harm Reduction, which that alone says a lot about how BHCHP really has taken on harm reduction being a really important part of the work that we do, and a focus of the work that we do. So I am very privileged to get to spend the majority of my week outside on the street. I started as a harm reduction nurse in our harm reduction program, where I was part of a really beautiful program called SPOT, as well as I ended up spending about like 5 to 7 days a week on the street. It's such beautiful work that it was really hard to like pull back and come inside. I also got really amazing opportunities to work with eHope. Adore Jim and everything he does. But yeah, the two things I really wanted to talk about today as kind of key pieces of our program are first our SPOT program and then our overdose response, compassionate overdose response that we've been building out. So SPOT is a place within our main campus where patients can come, clients, peers who are at risk of overdose or may have just had an overdose and need medical support afterward. So oftentimes clients will come in and they'll let us know, hey, I just used, I know it was sedating. I'm a little concerned about what I used. I just want to be in a safe space. And we're like, yeah, come on in. So we'll be able to put them on a vitals machine. If anything happens, we're able to immediately respond with medical interventions. Primarily, that's going to be oxygen, ventilation support. A really beautiful thing that happens is that oftentimes people will bring their peers in. So we have a lot of self-referral, but we'll also have clients who will say, hey, my friend is like in a bad place right now and they just need a little support, and they'll bring them in. We have over time built good relationships with different parts of the community. So EMS has brought people to us. One time I got to work and there were state police officers from the airport who had found someone in a bathroom and were like, hey, we heard you have this place. And we were like, yeah, bring them on in. Which, you know, we have a tense relationship with the police, but like we not gonna lie about that, but it's really beautiful that there's those pieces that we can work on where we are in some respects on the same team in helping people get to a place where they're not going to have a fatal overdose. So I'm more than happy to work with anybody in that respect. Something that also comes out of the work that we do is this really strong emphasis on listening to our clients and their specific needs that I don't always see the more that I have kind of come into this world of healthcare. I started as a researcher. I was in research for 10 years, like pure academia. I felt so far away from things and decided to come back, become a nurse practitioner. And the more that I'm involved in healthcare, the more I'm like, okay, we are trained so much that our priorities for the patients are what's important. And really harm reduction is bringing that back to a place of what are the priorities of my patient? How do I meet those? A little bit of a flip on that. And so something that SPOT's done is when we started, it was really about sedation monitoring. We started in 2016. It was purely medical monitoring. And now, based on things the clients had wanted, we do a ton of different things in this space. We have case management, we have wound care, we have harm reduction techs who are EMTs we've hired who can help support that medical monitoring so the nurses can do more medical care. The case management that we do out of that space is extensive, and what we call it is low threshold work. So we are in the same building as our primary care clinic, very classical kind of setup. But for some of our patients, getting through that process of going up, checking in, being in the waiting room, waiting for a case manager, it can be an extensive amount of time. And if that's really difficult for them, they can just pop in a spot and we can help them. So we really love that, like everything we've built is really come out of listening to our clients and what they're asking for and what they need. And in that same kind of vein, something that we've been working on lately is really a focus on compassionate overdose response. We've been doing this for a very long time, and it wasn't until pretty recently that we were like, oh, we should maybe like put this into a protocol. So back during COVID, the city of Boston set up these things called comfort stations where they were areas where people who were using drugs could use drugs without prosecution. It was outside, it wasn't great. It was similar in some respects to an overdose prevention site, but it didn't offer necessarily the dignity, the respect that people deserve in having like an actual brick and mortar. But what it did provide is a space where people could come and use, and we were able to respond very quickly if people overdosed. So at the height of the comfort stations, we were responding at times to about 10 overdoses a day. Like our quiet day would be 2 or 3. And through that work, we realized just how much we don't need to use naloxone. When we have the interventions to support ventilation, and provide that supplemental oxygen right away. So clients knew that the moment someone went out, they call us in, we throw in the oxygen, we throw in the pulse ox, and we oftentimes didn't have to give any naloxone at all. If anything, we were giving very small doses of naloxone, which we refer to as baby doses. And how I knew that this was going really well was that oftentimes newer people, especially as kind of those beginning months of the summer, we had new people coming in, people would be like, don't Narcan, don't Narcan. And the clients would be like, don't worry, it's just the nurses. Like, if they need to give Narcan, that person needed to give Narcan. And we're like, yes, beautiful. So we decided to put this into a protocol, and we built this OD response chart. That's 6 stages, and it really breaks down the clinical assessment into the most basic parts that we kind of think about when we get to an overdose. So we're looking at respiration, we're looking at O2 sat, and we're looking at pulse. And as you kind of go through the chart itself, those vitals go down. And really, we don't start to consider giving 4 milligrams of naloxone, even a single dose of it, until this person is basically not breathing. And our starting O2 sat is around 70, where we're giving recommendations for using 4 milligrams. In those kind of spaces where you're in the, 70s, 80s, people are breathing 1 or 2. We're really focusing on trying to encourage people to use the 2 milligram or less. So oftentimes we're using 0.5 milligrams, 1 milligram, just enough to get that respiratory drive back. Definitely not to wake them up, because that's not my goal, but get them into a place where things are moving and they can start breathing on their own. And it's really worked beautifully for us. And our chart itself is pretty conservative compared to what we do. When we were looking at our data, in the conversations, we had collected a little bit of data on our responses, and oftentimes we weren't giving naloxone until people were that starting O2 was like 50. And we didn't have a single fatal overdose in our entire time out there. So we're really proud of the fact that we're trying our best to kind of always consider what are the needs of our patients, and really meeting those. A lot of our programming comes with low threshold programs. We do a lot of street outreach across all parts of our program. We have really integrated systems of working with our HIV teams and our infectious disease team, our harm reduction teams. We often go out on outreach together, and it's all in this kind of concerted effort to make sure that we're responding to the needs of people who are using substances, especially those on the ground. So thank you so much.
For the record, nobody needed their timing, so you guys did an amazing. Okay. We have how many minutes? Maybe about 5 minutes if people want to ask questions. I just want to first thank the panel, guys. I think it is just so beautiful to hear about the work you do and to be able to share it and touch people's lives. And I think if people don't have questions, what I would ask is you turn to your neighbor and you tell them the 4 things that you're going to take away and change in your practice today.
May I ask a quick question?
After it gets, I want everyone to say what they're going to do. Okay, that's all the time you get. All right, I'm gonna bring everyone back. That's all the time you get. But now you have an accountability partner to enact whatever you decide that you're gonna be doing. All right, I'm gonna turn it back to questions. Heidi, did you wanna start?
2 quick questions. One is, how are you dosing the lower dose of naloxone? Are you using nasal, or are you doing IV or sub-Q? How are you doing the naloxone?
Just talk really close to the mic.
And then the second question that's part of that is, one of the things that I took away from yesterday was the idea of hypoxic brain injury. And as somebody's pulse ox goes down, at what point are we making sure that they come back and they're engaged and not also damaging their brain? So I love both of those. Thank you so much.
Thank you for your questions. So we primarily use this 2 milligram. We have them set up already as we go on outreach with us. So we don't necessarily have to do that in the field, because that can be really tough and stressful. When we're doing the lower dose lower dose administrations, it's really when we have that extra supplemental oxygen with us. So we never go on outreach without oxygen, or some way to like provide that oxygenation ventilation support. And we carry pulse oxes. We really try and make sure that we're able to make all those clinical measurements that we need to safely do this. So I could talk forever about our chart. That's like an hour long talk of its own. But it really, we made it so it breaks it down to you're first looking at what are my starting O2, my respiration, and then what is my oxygen level. So it gives recommendations on how to ventilate properly for like where you are with that oxygen saturation. We have ambu bags with us all the time. We use them constantly. And then there's also a secondary chart that gives recommendations on second doses. So we may start with, half a milligram a baby dose. And they're just maybe not recouping as fast as we want them to. That respiratory drug is coming back really slow. So then we might be able to give another milligram. But in total, right now, you're only getting 1.5 versus 8 milligrams because you've gotten slammed with 4 and another 4. It also is like very strong in its recommendations on timing. So we don't assess for even considering a second dose until that 3-minute mark and then giving a mark. So really just trying to like slow down the process of thinking through an overdose and just encouraging people not to kind of slam their hand.
Thanks. I have 2 separate questions. One is, anybody have any experience around aerosolized or nebulized Narcan administration, so that it could be user sort of driven or user determined? Typically when patients are becoming more aroused, they'll just remove that, and it's a good signal that they've gotten the dose that they need. So curious around if anybody could speak to that. And then sort of separate, more of a plug or a question is, how do we make these initiatives more sustained or ingrained in what we're doing? I find things like the Canary app, which I've been talking about for years, is just gone and no longer in the app store, right? And so it seems these harm reduction initiatives seem to come and go with funding. And so, it's frustrating at times when we're still funding how to integrate buprenorphine in primary care, which it feels like we were doing 10 years ago, and we're not being more progressive and putting our funding towards things like harm reduction initiatives, or even studying that and putting more credibility or literature to that to ensure that there's ongoing funding when we're competing with like state and federal regulations that still to this day, as someone who's practiced in South Carolina, don't allow needle exchange or needle distribution. So just wondering thoughts on that and how we can be more advocates of that ongoing funding and making that more of like a permanent line item.
Name and location, name and where you're from.
Sure. I'm Carolyn Bogan. I'm a nurse practitioner and I currently work for Commonwealth Carolines.
I'm gonna respond to some of that. I don't have any experience outside of the atomizers that we use with the 2. We very rarely use 4 milligram. But in terms of, I guess I want to put a plug out for like including harm reductionists and people who use drugs more in this field in order to keep all these initiatives going. So when we think about low dose naloxone, it's actually where naloxone started. Like Dan Bigger's, his focus really was on giving low doses of naloxone and trying not to induce precipitated withdrawal. And like we're trying to get back there. And I think that like, people who use drugs were more involved in these conversations and giving more, space at the table. Like maybe this stuff wouldn't go away. We wouldn't have to like get back to where we started. But that's just my opinion.
I'll make a comment about, well, first of all, aerosolized naloxone, I'm not aware of that being used like outside of like the emergency department, which I think it has been used there. One of the key points though is that people may still be sedated, but have good respirations enough to support, so they're not hypoxic. I think we want respirations to the point where people aren't visibly hypoxic. That's really important. And oxygen can be used, rescue breathing can be used. As far as like sustaining harm reduction, that is a huge issue. I'm really glad you bring it up. And you mentioned places like South Carolina, even in places, even like in California, Gavin Newsom vetoed their overdose prevention site bill. So none of these harm reduction things should we take for granted. I will say that there are things that are here to stay. I think in Massachusetts, syringe service is here to stay. Naloxone is here to stay. SafeSpot that I talked about. I'm not sure it's here to stay. We still, I didn't, no caveat that we haven't actually done research on it to show that it works. That's part of the plan, but we do have state support. It's not based on just volunteers. It's actually paid for. So the answer to that is like, we all have to decide as a substance use care community that it's important and we want to endorse it. So anyway, those were my thoughts.
Yeah, I would say there's even mayors in south of Boston who actually don't allow needle distribution in their town. So I think that just speaks to even the.
So a very important point, no mayor can restrict needle distribution in the state of Massachusetts. It is, the Supreme Judicial Court has said that needle distribution cannot be prevented. What the mayors can do is prevent this Department of Public Health from funding syringe service programs. So the Department of Public Health will only fund in communities where there is local approval. That should go through the Board of Health, not the mayor. So if you want to work on your own community and getting syringe service, it's already legal. If you want it to be supported by the Department of Public Health, you need to get your Board of Health to sign off on it. So just to get a little technical on the laws around syringe service in Massachusetts.
Also, if you're looking for a syringe service program near you, if you go on mass.gov and look up SSP or syringe service program, it will give you all the locations in Massachusetts.
Adding on, there's prescribers in this room. There's no restriction on you prescribing syringes to your patients. And there should be no restriction from Mass Health when paying for those syringes, regardless of the indication.
Hi, just need quick help. Some of the other managers, family and addiction from me. I work at Pines Health. It's a FQHC, and I'm trying to start to give out safe supplies. Does anyone know if I'm able to, because we're FQHC compared to other places where I can have the supplies in my office?
Healthcare for the Homeless, or Tehya Works, is an FQHC. So the FQHC alone does not prevent you from giving out supplies. There may be other issues in Maine that we can't.
So it's a lot of issues.
Yeah.
Thank you so much.